Myself, Dr. Neha Panse, Secretary, Society of Anesthesiology, Pune, welcome you all on this Neuroanesthesia webinar, which has been conducted by SAP in association with Society of Anesthesia Maharashtra State. Neuroanesthesia has always been a fascinating branch, and it is very critical. As the updates on advance, we also need to update ourselves as we indulge in day-to-day neurosurgeries. On behalf of SAP, I welcome all the dignitaries, speakers, chairpersons, and moderators to this webinar. Our Secretary, our Honorable President, Dr. Avinash Bhosle, sir, and Sheetal Madam couldn't join due to some emergencies. While they are not here, let's start this webinar. Neuroanesthesia has been fascinating and plays a crucial role in the outcomes of neurosurgery also. I now welcome Dr. Vikas Karne, sir, to kindly proceed on the proceedings.
Thank you, Neha, and good evening to all. And I think as we proceed, we know that neurosurgery is now coming to everyone's life, even to those who are not practicing neuroanesthesia routinely. And as neurosurgical procedures are happening more and more, there is a increasing trend to utilize the intraoperative neuromonitoring modality, and that is going to occupy all our lives, those who are going to participate into it. So today's webinar will have one presentation on that, and we will also have one presentation on TIVA, TCI-TIVA, which is a common modality, rather a gold standard when we are using intraoperative neuromonitoring. And as we proceed with the session, then we'll have panel discussion, which will be very interesting for all of us, as we all face emergency neurosurgical situations in our day-to-day practice, and not only for the neurosurgical procedure, but sometimes these patients come for the non-neurosurgical procedure, more commonly orthopedic procedures. So it's going to be an interesting situation. I'm thankful to all the faculties for joining us and welcome all the delegates. And I request Dr. Shalini Sardesai, Madam, President, Society of Anesthesiology, Pune, to proceed with her work.
Yeah. Thank you, Dr. Vikas Karne, sir. Good evening, everyone, and welcome to this very interesting webinar on update on neuroanesthesia. SAP is always grateful to the SAMs because of their continuous support, encouragement, and providing this platform to conduct various webinars. I think till date, this year we have conducted, this is the fourth webinar we are conducting in association with the SAMs. So for that, I'm really thankful to all office bearer, our President Avinash sir, Vice President Vikas Karne sir, Honorable Secretary Shilpa Dalal, and all office bearers for that. Before this last webinar, we have conducted on pediatric difficult airway management in association with SAMS and IAPA. So I'm very glad to share that almost that time 400 registrations were for the webinar, and out of that I think 200 delegates were attended it. And it was a really very interesting and interactive session, and overwhelming response from the delegate. When I discussed the idea of conducting this update on neuroanesthesia webinar with Dr. Vikas Karne sir, he readily agreed and immediately took an initiative to plan it, and immediately he executed it, and the result is here. All for the today's webinar, we got such an excellent speakers and faculty over here to enlighten us on neuroanesthesia. Today's webinar, I thought we will conduct on update in neuroanesthesia. Because most of the people, not everyone practice neuroanesthesia, but the faculty or the anesthesiologist, though they are not neuroanesthetists, working at the corporate hospital or at teaching institute, they have to give anesthesia to neurosurgeries many times. And now the incidence of road traffic accident is increased so much, so that polytrauma patient with head injury comes for either for laparotomies or many orthopedic surgery. So that's why it is very essential to update ourselves in this field of neuroanesthesia. And recent advances in neuroanesthesia are actually aimed at enhancing cerebral protection, improving hemodynamic stability, and enabling precise neuromonitoring. Notable trends include the resurgence of ketamine for neuroprotection, the increasing use of total intravenous anesthesia with propofol and remifentanil, opioid-free anesthesia using dexmedetomidine, and the expanding role of awake craniotomies. So today, for this executing this webinar, I really thankful to Dr. Vikas Karne sir and really appreciate his enthusiasm and commitment. And because of him, today we got today we are so privileged that we got an panel of excellent expertise in neuroanesthesia over here, who will share their experience, expertise, and give insight over the recent advances or updates on neuroanesthesia. And I'm confident about that today's webinar is going to be very interactive, informative, and very beneficial to all of us. So thank you everyone, and once again welcome for this webinar. Now, without any further delay, I hand over mic to Dr. Vandana Nande ma'am. She is Vice President SAP, to introduce our esteemed panelist, esteemed chairperson for today's session. Over to
Just a minute. Our President, Dr. Bhosle sir, has joined the meeting. I would like to welcome sir for this meeting. In spite of busy schedule from Gujarat, you have joined the meeting. Thank you so much, sir.
Oh, welcome,
Yeah,
sir.
thank
Welcome.
you. Thank you very much. Right now, I am at the Statue of Unity
Oh,
at Ekta Nagar. I am heading toward the Yuvakon, National Yuvakon at Ahmedabad
oh, acha, acha, acha.
tomorrow.
Avinash sir, thank you for joining.
Yes.
Yeah, I
Yeah.
am waiting for the laser show here.
Yes.
Okay.
So please,
Okay.
Nande madam, introduce our chairpersons for today's session.
Yeah. Thank you, Dr. Shalini ma'am. And once again, I welcome you all for today's webinar. To ensure our webinar runs smoothly, we have with us Dr. Pratibha Kane ma'am as a chairperson for today's session. Dr. Pratibha Kane ma'am, who is not only mastered anesthesia, but also law and personal management with gold medal and honors. She is certified in healthcare from Oxford University. She has shouldered the responsibility as a president of ISA Pune City in past. She has a publication in diverse topics besides anesthesia, like stress among the nurses, communication skills, legal aspects of renal transplant, and she has also co-authored study regarding major complications following neuroaxial block in Indian Journal of Anesthesia. At present, she is senior consultant at Jahangir Hospital, Pune. Welcome, ma'am. And Dr. Rajeshri Devpulpuri ma'am is unable to join us today in view of some emergency. We shall definitely miss her. Welcome, ma'am. And I request Dr. Sumedha to introduce our speakers.
Thank you, Vandana ma'am. Can I have a slide, please? Dr. Bhave is consultant neuroanesthesiologist affiliated to Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. Sir has a special interest in stroke intervention, neuromonitoring, and awake craniotomy. My next speaker is Dr. Joseph Monteiro. Sir is senior consultant neuroanesthesiologist at Hinduja Hospital and Medical Research Center. Sir is program director of neuroanesthesia and neurocritical care program. Sir is highly accomplished academically with special interest in neuromonitoring and neurocritical care. I now request Dr. Bhave to begin with the session.
Thank you, respected chairpersons, office bearers, and the Society of Anesthesiology Pune for allowing me to share my thoughts, my opinions, my presentation in front of you. I will now start sharing my screen. Is my screen visible? Hello?
No, sir.
Not yet. Not yet.
Hello? Is it visible now?
No.
No, no.
Okay. 1 minute.
Does he have to be made a co-host?
No, that is
Ganesh,
not
are you
Ganesh.
there? Ganesh, are you there?
Ganesh.
Please help.
त्यांना co-host करायला लागेल मला.
मी शेअरचा ऑप्शन येत नाही. 1 minute.
Settings मगाशी होत होते ना सर.
We actually checked his presentation.
मग
Ganesh, are you there?
हा, before the meeting it was getting shared. Yes.
Yeah.
All right. So
No.
my is it visible now?
It's gone.
No, again it is gone.
No. It is gone. We were able to see it, but now it is gone.
Okay.
Yes.
Ganesh, are you there? Yes.
Yeah.
We can see now. You can start.
All right. So my
Yeah.
topic for today is intraoperative neuromonitoring in brain and spine surgery. So I'm discussing my topics under these following headings. I will introduce the topic, then which all are the modalities that I will highlight, surgical indications, then anesthesia and intraoperative neuromonitoring. So what is intraoperative neuromonitoring? It is a real-time specialized technique which is used to assess the functional integrity of the brain, the spinal cord, and peripheral nerves during surgeries. It provides an early warning of potential insults by enabling early interventions, and it helps to identify functionally eloquent areas of the brain, spinal cord pathways, and nerves, that is both cranial as well as peripheral nerves. So when did it start? The first documented use of neuromonitoring starts way back in the 1870s when Richard Caton used a galvanometer to demonstrate electrical activities in animal models, which was whose work was then cited by Hans Berger in 1920s when he demonstrated alpha waves on the in the brain. That was first demonstration of EEG. The first application of anesthesia for somatosensory evoked potential was by Dr. Grundy in the 1960s. She was one of the pioneers in anesthesia for SECP, somatosensory evoked potential. Then Robert Levin demonstrated the brainstem auditory evoked potentials in 1970s, while this is the first demonstration of transcranial magnetic electrical evoked potential. So which all are the modalities in clinical practice that we use? The modalities can be divided into spontaneous and modalities that evoke a response after a stimulation. So the spontaneously generated modalities that we can see are the EEG, that is electroencephalogram, the electrocorticography, and electromyography. And stimulus evoked responses are EMG, that is in response to central or cranial or peripheral nerve, somatosensory evoked potentials, transcranial motor evoked potentials, brainstem and visual evoked potentials, compound nerve action potentials, and direct stimulation of the eloquent brain cortex, that is direct cortical stimulation, and direct spinal cord stimulation or spinal cord recording using D waves. So I'll be covering most of them in my talk. So let us start with electrocorticography. As you can see in the picture, it is an invasive procedure where a strip or a grid electrode is placed over the cerebral cortex. So for that, you need to do a craniotomy. That is why it is an invasive procedure. The advantage of the electrocorticography over the surface EEG is that the artifacts that you can get potentially on the surface EEG are minimized. But patient has to undergo a craniotomy. So when is it used? It is used in cases of epilepsy surgery prior to resection and after the resection of the epileptogenic cortex. If the surface EEG is unable to pinpoint or unable to localize an epileptic focus, then this electrocardiography can be used to diagnose or to localize the site of epilepsy. Then somatosensory evoked potential, it monitors the integrity of the spinal cord and the sensory pathway, that is the posterior part of the spinal cord. It monitors the integrity from the peripheral nerves to the posterior column, that is the dorsal column, medial lemniscus. Then as we ascend up to the midbrain, medulla, medulla, pons, midbrain, thalamus, and to the primary sensory cortex. The indications of somatosensory evoked potentials are the spine surgeries, that is right from placement of pedicle screws to scoliosis correction to intraoperative neuromonitoring for intradural or or intramedullary tumors. These are the indications for spinal surgery, or any cervicothoracic or lumbar meningocele or meningomyelocele. Then cranial surgeries where you have to localize the central sulcus by using the phase reversal, excision of tumors involving the brainstem, and the neurovascular surgeries like aneurysms, AV malformations, excision, or extracranial to intracranial bypass. They can be used in vascular surgery where we need to assess the spinal cord functions, like in placement of aortic stent graft, where the spinal arteries arise from the aorta directly, or in carotid revascularization procedures where the patients would be prone for stroke intra-procedure. This is transcranial motor evoked potential, which monitors the integrity of the spinal cord and the motor pathway, that is the descending pathway. But it requires a higher current than somatosensory evoked potentials. Therefore, to get a transcranial motor evoked potential, one has to administer general anesthesia. So as you can see in the picture, it monitors the lateral and ventral corticospinal tract, and also the descending pathways from the motor cortex to internal capsule, midbrain, pons, medulla, and the spinal cord. Indications more or less the same as the somatosensory evoked potentials. One has to remember that isolated somatosensory evoked potentials or motor evoked potential, isolated will not be able to give you the full function of the spinal cord. So they have to be used together if you have to monitor the spinal cord functions, and that is why we have to do it under general anesthesia. Coming to visual evoked potentials, which monitors the integrity of the optic pathway from the retina to the visual cortex. The main indications are surgery for tumors in and around the optic nerve, pituitary tumor excision where the macroadenoma compresses the optic chiasm, surgery around the visual cortex or around the optic radiations or in the pathway of the optic pathway, anywhere the tumor is. And one more indication is deep brain stimulation for dystonia, where the target is the globus pallidus internal, which is placed near the optic radiation, where because of the significant dystonia, the DBS has to be performed under general anesthesia. So we had published one article where we had used direct optic tract stimulation in deep brain stimulation for dystonia, where you can see here is the internal capsule and basal ganglia, one of which will be the globus pallidus internum, and corresponding post-lead placement, you can see the two dots here. These are the leads. So just for your understanding, and these are the visual evoked potentials which remained stable throughout the procedure. This was done under general anesthesia using dexmedetomidine and propofol, and depth of anesthesia was used using BIS, and we had kept the BIS during the stimulation part to 60 to 70. Patient came out well. coming to brainstem auditory evoked potentials, which monitors the integrity of the auditory pathway from the inner ear to the auditory cortex. So it can be divided into low latency, early latency, that is up to 10 to 50 milliseconds, that is the up to the brainstem. So these are the auditory potential waveforms, where the generation of which you can see here, and up to wave. These waves are most resistant to anesthetics, as we can I will show you later. So indications for brainstem auditory evoked potentials include inner ear surgery, brainstem tumor excision, cerebral pontine angle tumor surgery, basilar artery or intradural vertebral artery aneurysm surgeries. So last is the triggered EMG, where we evaluate the functional integrity of the motor nerves, which can either be cranial or peripheral nerves. So this figure shows the placement of the stimulator, the recording electrodes at various points, where depending on which cranial nerve you have is of interest for you. So if you are looking at extraocular muscles, so this is where you have to put it in the extraocular muscles. For seventh cranial nerve, that is facial nerve, frontalis, orbicularis oculi, orbicularis oris, and mentalis. 4 muscles you can put. For trigeminal, the muscles of mastication, that is masseter. For 8th cranial nerve, we can see here the brainstem auditory evoked potentials. For the 11th cranial nerve, the trapezius or sternocleidomastoid. 12th cranial nerve is the hypoglossal nerve, where you have to put the electrodes on the tongue. For the 9th cranial nerve, you can put the electrode in the soft palate. That is, you do a laryngoscopy, and using a forceps, the electrodes are placed. This even the 10th nerve can be stimulated by this, because the gag reflex, one pathway is via 9th nerve and another pathway is via 10th nerve. Another way you can stimulate is by putting electrodes in the cricothyroid membrane. This tube that they have shown is a specialized tube that I will show you later. It is called as NIM-FLEX tube, that is nerve integrity monitor tube, which has electrodes embedded in the tube itself, and these electrodes have to be placed around at the level of the vocal cords, and this will record the stimulation of the 10th cranial nerve, that is vagus. Indications for triggered EMGs include both central nervous system surgeries as well as peripheral surgeries. CNS surgeries that are tumors or lesions involving or in close proximity to cranial nerves, brainstem tumors where the nerve nuclei are, vascular surgeries in and around the brainstem, and epilepsy surgery like the vagus nerve stimulation surgery, where you have to stimulate the vagus nerve. The indications of the EMGs in peripheral surgeries are also gradually increasing. That is, thyroid surgery, where you encounter the recurrent laryngeal nerve, parotid surgery, where the facial nerve is in close proximity. For peripheral nerve surgeries like brachial plexus or lumbar plexus surgeries, any tumors involving the peripheral nerves, or if there is a traumatic injury to the nerve and you need to do a reconstruction using a sensory nerve, then you can use the triggered EMGs to identify the nerves. And in pediatric patients, if there is a low-lying meningomyelin, or if there is a tether cord, to differentiate the phylum terminal from the nerve prior to detethering, you can use the triggered EMG. So last monitoring parameter that I have here with me is the direct stimulation, that is direct stimulation of the brain or the cord, spinal cord. So brain stimulation using the monopolar or bipolar stimulator, and spinal cord using the D-wave stimulation. So coming to the indications and the uses of these intraoperative neuromonitoring modalities. So coming to supratemporal surgeries, as we know, this is the lateral surface and the medial surface of the brain, where this is the central sulcus that is marked in the green arrow. Anterior to it is the motor area, and posterior is the sensory area. And in the inferior frontal and the superior temporal region of the dominant hemisphere, you can see the speech area. The frontal area is the Broca's, that is the motor, and the temporal is the Wernicke's, that is the sensory area. This is the sensory and the motor representation of the brain, that is called as the homunculus. And based on that, we can decide what area to target when we are doing the intraoperative neuromonitoring in cranial surgeries. So along with the neuromonitoring, important thing required for planning is imaging, and detailed imaging at that. So based on the location, you can see that this is a large tumor in and around the central sulcus. But this will help us more if we get a tractography, which is shown here, where the tracts you can see are displaced posteriorly, as well as functional imaging, that is functional MRI of the brain, showing the relation of the leg area on the right side with the lesion that is placed here. So all these help us in planning our neuromonitoring and what modalities to be used and what to expect during resection of any intracranial pathologies. All this with intraoperative navigation and tractography help us in better delineating and better planning our plan of action. So this is the intraoperative monitoring where we are using the 1 minute. I'll just do the video. 1 minute. You can see the somatosensory evoked potentials, where we can identify the central sulcus, that is the phase reversal on central sulcus, that is seen here between the waveform 2 and waveform 3. So central sulcus will be lying in between the electrodes that is placed on the brain, the second and the third electrode. So this phase is going up, this phase is going down. So the phase reversal is here, and this is how you can see the SSCP. This is a awake craniotomy patient where we are doing the central sulcus mapping using the phase reversal. This is the by this we'll be able to identify which is the hand area, leg area, and then you can use a direct cortical stimulation. Where we are stimulating the cortex, and the other area you can see the spontaneous or reflex movement of the upper limb. So this is the direct cortical stimulation to identify the eloquent cortex, eloquent motor cortex. Then monitoring and mapping of the speech area, where
Factor counting. Yes, she's getting one.
So again, similar patient where we could monitor the speech area, and based on the location of the speech area, we can isolate and highlight these areas and stay away from these eloquent areas. So along with this, we need intraoperative manual testing, where we can test both all are part of awake craniotomy, where we are getting the patient's cooperation, and patient is actively participating in the monitoring methods. So coming to infratemporal surgery indications, cerebellopontine angle tumors, brainstem tumors like it is shown here, pontomedullary tumor that is here, are the major indications for infratemporal tumor surgeries. Then spine surgery like craniovertebral junction anomalies that you can see here. See the signal changes in the spinal cord in this image here. Cervical intramedullary tumors where you need SCCP and MEP. Thoracolumbar tumor, intramedullary tumors, and pediatric patients, that is lumbar meningocele, meningomyelocele. Note we have used bispectral index in pediatric patients here for depth of anesthesia monitoring. So coming to anesthesia and intraoperative neuromonitoring. So our plan starts from building of the rapport when we first interact with the patient. And if the patient is to undergo surgery under awake craniotomy for cranial surgery for eloquent cortex lesion excision. So our rapport and our interaction should be such that the patient gets so from a very anxious patient, like you can see in the feeder animations in awake craniotomy, and again identification of the potential difficult patients that you can encounter for awake craniotomy. That also needs to be highlighted to the surgeon when you visit the patient. So skull block and having the airway cart ready is very important. As you can see here, the scalp is supplied anteriorly by the branches of the trigeminal nerve and posteriorly by the posterior ramus of C3 and C4. So this is our theater layout where you can see surgical team is at the head end. There are transparent drapes and the anesthesiologist is able to see the patient's face clearly. Patient is also able to see the anesthesiologist. So that negates the chance of claustrophobia and fear that I'm all alone. That fear goes and patient can and is able to communicate very well with the anesthesia team. So there are two ways you can go about it. Patient who is spontaneously breathing and just sedated, we use from in our setup, we use infusion of dexmedetomidine up to 0.2 to 0.7 mics per kg per hour and propofol 0.2 milligram per kg per hour, bolus doses of fentanyl, titrated bolus doses of fentanyl. Epilepsy surgery, we will avoid midazolam, otherwise we will give midazolam. We tried using remifentanil for awake craniotomies, but in 2 patients, we could find one loss of airway and second uncontrollable rise in blood pressure, because of which we had to convert into general anesthesia. So we are using less remifentanil for awake surgeries, but we are preferring dexmedetomidine and propofol infusions for awake craniotomies. So coming to intraoperative neuromonitoring under general anesthesia, as I had mentioned before, this is the NIM-FLEX tube, that is nerve integrity monitor tube, which this band here is placed around the vocal cords, as you can see here. So color coding, red for right, blue for left, and placement of bite block is very important to prevent injury to the lips, tongue, and the endotracheal tube. We used to use silicone bite block, but 3-4 patients had significant lip swelling, lip injury, tongue injury. So we prefer to use rolled gauze pack, centrally and one syringe placed laterally between the teeth. So that has given us better results. So this was our article that we had used nerve integrity monitoring tube in patients undergoing posterior fossa surgery. We had presented a series of 5 patients. This is 2019. So coming to placement of electrodes. Placement of electrodes in the scalp is based on the 10-20 system, where you can see here the CZ, FZ, and lower one is the CZ prime, and anteriorly these two are the for motor evoked potentials, and these two C3 prime and C4 prime for the sensory evoked potentials. This is C1 and C2. So intraoperatively, this is how we place the SCCP electrodes. Forms that you get, depending on the color coding, the green is the most recent one, the red is the baseline, and what you get, the white one is the average. So SCCP requires averaging, so that is why you get the average wave. So as you can see here, the N20. So by convention, any upward deflection is labeled as N, and any downward deflection is labeled as P. So P44 and N22 for lower limb and upper limb respectively are normal. So which all modalities and their sensitivity to anesthesia. So VEP is the most sensitive to anesthetics, followed by NEP, then SCCP, and brainstem auditory evoked potentials are the most resistant to the anesthetics. With different types of anesthesia, volatile agents affect the neuromonitoring modalities more than the intravenous anesthetic agents. Higher the MAC, more the effect, depressant effect that is. So what do you mean by depressant effect? That is increase in latency or decrease in amplitude. So many articles suggest use of MAC less than 0.5 can be safely used, and you can get a good reading in the monitoring parameters. However, TIVA is considered to be the preferred option, with remifentanil and propofol having their own TIVA-based pharmacokinetic-based models, about which Sir will be talking later. So they are the most popular and most commonly used models and most commonly used drugs for the TIVA. Muscle relaxants, only intubation doses, and one has to allow the effect to wear off before recording the baseline to prevent any false readings. Then benzodiazepines are avoided in epilepsy surgeries. The newer benzodiazepine, that is remimazolam, has shown promising results, and there are many studies that are going on regarding remimazolam in IONM. I will show it later. Opioids, remifentanil is the best for IONM because it has the least influence, and infusions are better than bolus doses. If remifentanil is not available, you can use a infusion of fentanyl of 0.5 to 0.7 to 0.1 mics per kg per hour. If remifentanil is not available, one can also use dexmedetomidine, that is used in the doses of 0.3 to 0.7 mics per kg per hour infusion. But one has to remember that should not combine dexmedetomidine and remifentanil because the bradycardia will be exaggerated. Ketamine is an analgesic adjunct which has been shown to have enhanced, which has shown to enhance the SCCP and MEP signals, and can be used if the signals are low or if you are getting drop in the signals. Etomidate can also cause increase in the signals, but it has gone out of favor due to other side effects. So etomidate is less favorable than ketamine. So coming to remimazolam on intraoperative neuromonitoring, there are articles on thyroid surgeries, on visual evoked potentials, and during spinal surgeries. where spine surgeries, they have compared remimazolam and propofol, and it is shown to be a safe and alternative anesthetic in spine surgeries. And here they have used in thyroid surgeries, and here visual evoked potentials. Then this is ketamine and intraoperative neuromonitoring. There are articles here. In this study by Khandelwal et al., they had used a combination of propofol. They compared propofol and ketofol, where they compared they combined ketamine and propofol in the dose of 1:4, ratio of 1:4. So what do? We use a combination of oxygen and air in 50% concentration. Use inhalation agent sevoflurane, MAC less than 0.5. Single dose muscle relaxant cisatractide 0.2 milligram per kg for intubation. Infusion, we use propofol 0.5 to 1 milligram per kg per hour. Remifentanil, if we have the TCI pump, 3 to 4 nanogram per ml effect site concentration on fever, or 0.05 to 0.2 microgram per kg per minute if TCI pump is not available. If remifentanil is unavailable, then use dexmedetomidine 0.3 to 0.7 mics per kg per hour. If ketamine is to be used, use infusion of 0.2 to 0.5 milligram per kg per hour, and always use bispectral index monitor or any other monitor for depth of anesthesia. So which are the factors that affect neuromonitoring? One is the depth of anesthesia, then positioning, that is if the patient's spine is unstable or there is excessive rotation of neck over the head, or if there is increased traction on the limbs, then the post-positioning waveforms will be lost or will be of a lesser amplitude than what you get during the baseline or immediately after the reversal of the muscle relaxation. Then hypotension, hypothermia, hyperthermia, anemia, hypoxia, hyper or hypocarbia. These are the factors that affect neuromonitoring. Then there is some words about D wave, which is this D wave is most resistant to damage, but it has to be placed if the tumor or if the lesion is above the L1, where the spinal cord ends. So it monitors the integrity of the spinal cord. So we have to place the electrode subdurally below the level of lesion, and it should be placed in the caudal direction. But when you place the D wave, the stimulation that is caused by the D wave results in loss of the signal of your depth of anesthesia monitor. So it becomes unreliable. So we have to rely on the spectral edge frequency on the electrophysiological team's monitor to get the anesthesia depth, where a value between 12 to 18 is considered to be acceptable. So one case we had presented here, where it showed, you can see here, once the D wave is stimulated, D wave is switched on, you can see the bispectral index value going, but you can see spontaneous EMG activities here. But these are the stimulation of the D wave, where once it is placed. So what happens when there is increase in amplitude or a decrease in latency, which means when you get an alert from the neuromonitoring team, what has to be done? So surgical team, anesthesia team, and neurophysiological team, that is the team that is handling the neuromonitoring device, all have to work together. And we have to pause the case, announce signal change, inform the teams, and then from the technical side, see whether the connections are intact. Then rule out artifacts, check whether there is any suction artifact or any from the anesthesia team, see if there is no injection of any anesthetic agent that may cause a drop in the neuromonitoring modalities. Check position, and then if patient is hypothermic, make the patient normothermic, hyperthermic, normothermic. Increase the blood pressure to 20% above the baseline. If patient is anemic, transfuse blood, maintain normoglycemia. So these things the anesthesia team has to do. Surgical team, stop the surgical stimulus that has resulted in the neurological neuromonitoring alert. Irrigation, if there is vascular surgery, you can there may be vasospasm, give papaverine, or any emergent imaging if you need, you can do. And make an informed decision whether to go ahead with the surgery or stop and wait till the signals resume. And once the signals resume, whether their what all parameters resulted in the drop, it should not reoccur. And one has to have a safe surgery for the patient, because finally it is the patient that has to benefit from all our efforts. So that is the ultimate goal, that the surgery should be safe. So my takeaway is, it is all teamwork. It is continuous interaction between the surgical team, the anesthesia team, and the neurophysiology team. And if everybody is in sync with each other and does a coordinated and nice communicating job, the results will be good, the results will be the best, and the patients will go back home happy, and everybody will have gotten the uh, satisfaction that we have done a good job for the patient. So it's all a teamwork where everybody achieves good success and good results, and patients in the end are very happy. Thank you.
Thank you, Dr. Bhave. That was a very, very detailed explanation. I have actually two questions for you. Have you ever refused a surgeon that you will not do an awake craniotomy?
Yes, madam. Main criteria for refusal is patient cooperation or the lack of it. If you in your assessment feel that this particular patient is either not of a sound mental status, preoperatively only if you are able to assess, he will not be able to cooperate, or he is extremely claustrophobic, extremely anxious, despite your best efforts, you are not able to convince him, then and there you have to switch to your plan B, saying this will not be possible in awake craniotomy. You can use GA with neuromonitoring. That is fine. Secondly, people used to say difficult airways, potentially difficult airway patients, but with faster onset and offset medicines like remifentanil, that issue is not an issue technically, but then you have to know how to use remifentanil judiciously. So,
and have you ever had to, kind of abandon the awake procedure and intubate at any point?
two patients,
Okay.
we had used remifentanil. Actually, I did not put the patients in our slide. 1 minute, I will show you. 1 minute.
Neha, we will quickly move to next presentation once this question is answered.
I now request Dr. Vandana Madam to introduce Dr. Monterey sir, and sir will start the presentation.
So this is the remifentanil, where you can see the pressure had gone up so high, and ET2 was rising. The moment we put in the LMA, the pressure settled. This was despite giving maximum doses of NTG and labetalol, all antihypertensives what we had in our armamentarium we used, but we are still not able to control the pressure. The moment we secured the airway, the ET2 dropped. This was our second case where again we resulted fall in saturation and rise in ET2. So prior to positioning only, we had to secure the airway. So these were the two patients that we had.
All right. Thank you so much. Thank you for those explanations.
Thank you.
Thank you, Dr. Chinmay. Now we request Dr. Montero sir to begin with his presentation, please.
Okay,
So, good evening, all. And am I audible?
Yes, sir.
Yeah. So, good evening, all, and many congratulations to Society of Anesthesiologists Pune in collaboration with the Society of Maharashtra State Anesthesiologists for this initiative in passing the message of neuroanesthesia all around the state. So, my topic for today is TCI, TY, neuroanesthesia. Anesthesiology, as we know, and neuroanesthesiology, as we know, has progressed over the years. So you can see the progress of anesthesia as it progressed over the years, and we are always evolving to try to get better and better as we go ahead. So why this folk change from volatiles to TIVA? So this is not exactly a cultural change, but it is a mindset change that we must do if we want to transport ourselves from the volatile anesthetic use to a total intravenous anesthesia use in neuroanesthesia. So which anesthesia technique you think is appropriate for neuroanesthesia? So this is a schematic that is showing you the effects of the various drugs that we commonly use and the effects on cerebral blood flow and CMRO2. So just coincidentally, the colors match the color of a national flag. So we see right in the top corner drugs increasing the cerebral blood flow and CMRO2, that is nitrous oxide and ketamine. In the left panel, we see in green all inhalational agents increase the cerebral blood flow in a dose-dependent manner, and they also decrease the cerebral metabolic oxygen consumption. We can see right at the bottom is sevoflurane, next is isoflurane, then comes desflurane and halothane, which we have long given up. And in the bottom left corner, you can see all drugs decreasing CMRO2 as well as decreasing cerebral blood flow. So it's a no-brainer, pun is not intended, that they consist of all the opioids and all the induction agents that we know. So it is the benzodiazepines, remifentanil, fentanyl, etomidate, propofol, and the barbiturates. I've also added dexmedetomidine here, but dexmedetomidine is not an anesthetic agent, but it is an adjunct. It's an alpha-2 agonist, and it helps to reduce the dose of your intravenous anesthesia or your general anesthesia. Most important to note is then it's obvious that a total intravenous anesthetic technique will be best for cerebral hemodynamics as well as preserving neuronal function. You have to avoid changes in concentration or bolus drug deliveries during critical monitoring periods. Now, what we say is the critical monitoring period. The critical monitoring period can be any time during the surgery. So it's very important that the anesthesiologist is involved throughout the surgery and knowing the steps of the surgery so that you don't administer any bolus drug during those critical periods. So go back in history here. Now, see, there was a cultural change for me too. So in 1998, when I went to Cambridge and Allen Brooks in Cambridge, we had done the study, propofol anesthesia for craniotomy, a double-blind study comparing remifentanil, alfentanil, and fentanyl. And we surmised then, and this article was published in Journal of Neurosurgical Anesthesiology in 2000, that there was no significant differences among the groups. And they felt that remifentanil is an appropriate opioid to use in combination with propofol during anesthesia for supratentorial craniotomy. That was so many years ago. Unfortunately for us, remifentanil took a very long time to come to India, and now it's available in many centers, including ours. So just for the knowledge of the postgraduate students, if they are there on the site here, that it is a phenylpiperidine derivative with the ester linkage, which provides its unique and favorable pharmacological profile. It is a white amorphous powder. It forms a clear solution on reconstitution, and it's a pure mu receptor agonist. It uses glycine as a preservative, which is neurotoxic. So it's very important to note that remifentanil should not be used in central neuroaxis blocks. Like how you add fentanyl to your central neuroaxis block, you should not use glycine as a because it contains remifentanil contains glycine, and this is neurotoxic. Remifentanil also has got linear kinetics, and hence it is metabolized by the esterases in the blood. Fentanyl has non-linear kinetics and it has a cumulative effect. So what are the doses? The TIVA doses are, as in the screen here, If you're using it as a TIVA form from 0.05 microgram per kg per minute, and you can increase it depending upon the depth of anesthesia that you want. The TCI dosages are given on the right with in nanogram per ml. So for sedation and awakening at the pre-induction stage, we give about 1 nanogram per ml. And perioperatively for lighter pain, you can increase it gradually to about 2. And for surgical anesthesia, we maintain it between 3 to 6 in a TCI dose. We use a target site concentration for surgical anesthesia. Once again, I will reiterate here that remifentanil is a very powerful opioid, and if it is given in a bolus, the side effects which malign it are more. So it's always good to use it as an infusion. You see here in this graphic the context-sensitive half-life of remifentanil. It is the bar right at the bottom. It is just 3 to 6 minutes. Whereas fentanyl, you can see here, it gets accumulated and it has a very long context-sensitive half-life. It's very important to know the context-sensitive half-life when a drug is being used repeatedly or in an infusion. Once again, only infusions, no boluses. And apnea and bradycardia, which are the most common side effects, are amplified on bolus administration. Next, we move on to the TCI. It is an AI-based technology that reverse engineers the pharmacokinetics and adjusts the infusion rate to achieve and maintain the target drug concentrations. In remifentanil, you can use the Minto model, or recently we have got the Elevate model, which is a more versatile model to be used across patients and across drugs. So what do you set on the interface? I will go into later, but the name and concentrated drug, the patient details, age, weight, height, and gender. And then you can also choose whether you're using a plasma site or effect site model. And what you also set the target concentration. So this is an image of the syringe set up in the morning. Very important to draw up your drug yourself. And we draw it up in the same dose. So if it is 2 milligram, we make it up to 40 cc, it was 50 mics per cc. And here you can see here, if you use the drug in the proper dose, it doesn't create, it is a safety mechanism. And it's also important that you draw it up yourself and label the syringe properly. As you can see here, you can see here the element model, what is the concentration, and you have chosen the effect site. So, okay, now let me see whether the video plays. So after the induction, when we moved on to the intubation, and we have increased the dose here, you can see how the effect site is increasing to achieve whatever you have set. So once again, to tell you, concentration 50 mics per ml, and these mathematical calculations derive a simple formula. So you don't have to be, as I say, Arya Bhatta or somebody to come to this calculation. So weight in kg into 0.12 ml per hour gives you 0.1 microgram per kg per minute. If you double it, it becomes 0.2. If you half it, it becomes 0.05. So it's the uses now. See, you can see here, it is very potent as compared to the fentanyl-based regimes. It can facilitate intubation without muscle relaxant use. So that may be very good in those intraoperative neuromonitoring cases that Chinmay spoke about. So you may not have to give too much of a muscle relaxant, and it prevents intubation-related hemodynamic effects, alterations. So now just shifting over, I'll quote Atul Gawande, who said that better is possible. It does not take genius, it takes diligence, it takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try. So here we are on this platform trying to get better and trying to discuss topics that will help us to improve ourselves and our practice. I'll share with you a few videos which I've got. You can see the stable hemodynamics in the left image, and remifentanil going here. But now here, this is the older TCI pump that we had. I also use it in aneurysm clipping, where I start the remifentanil infusion even before I intubate the patient, because the risk of aneurysm rupture is maximum at the time of induction and intubation. So I put my arterial line to under local anesthesia. Once again, you can see stable. Now I don't see when you're checking it's very important to check the mean arterial pressure, which is equal to the cerebral perfusion pressure. once the dura is open. So now you can see here the rate is 60. Don't get too much distracted with a rate that can be about 40 or 50 or 60 with the use of remifentanil, as long as the mean arterial pressure is being maintained and cerebral perfusion pressure is being maintained. This is a case where I've used it in awake craniotomy. I use a very, besides, see, scalp nerve block is the cornerstone of your awake craniotomy. But I've also give a very small dose of remifentanil. It decreases those aches and pains, and when the patient is not yet being tested. This is a case of awake lesioning. Patient with a scalp block, undergoing a panidotomy procedure, fully cooperative. And you can see she's an elderly lady. I also like this effect of using a plastic drape here, so the patient gets a perception of light and feels seen in contact with us. Another very tricky procedure that we do in neuroanesthesia, the endonasal. Because the endonasal procedure, it can be very painful. The anesthetic depth has to be altered very often during the procedure. And previously, we used to use vasoactive drugs like nitroprusside or esmolol to control the pressure and control the hemodynamics. But with the advent of remifentanil, we achieve the same without using vasopressors, vasoactive drugs like nitroprusside or esmolol. We can control the pressure very easily. So you see the procedure, you can see the surgical stimulus, and accordingly you adjust the dose. This is another case of a wake-up test and lesioning which we did. We did it for the first time. So here we wanted the patient to be intubated. He was a case of dystonia who had very which had very aggressive movements which had to be controlled. So I intubated him with remifentanil, very a touch of propofol, and you can see the patient is here under anesthesia. And when we started testing him with the tube, he was tolerating the tube. And this is a case of bilateral deep brain stimulation. You can see the frame fixation is going on. Sometimes when the frame is being fixed and they pass those, those stabilizers into the ear, it's a very painful thing. So in the previously, we should just give paracetamol because there is scalp block. But a small touch of remifentanil helps at this time. So when you're using, this is a case of the DBS for dystonia. So important when you use TCI, TIVA or any form of anesthesia, that you have some amount of depth of anesthesia monitoring going on. This depth of anesthesia monitoring helps you to objectify the depth of anesthesia when you're doing this procedure. So you can also show it to the attending neurologist and the neurosurgeon. Here, this is the DBS with the microstimulation, and here, this is the microstimulation going. And our neurologist doing the macrostimulation. Nowadays, most neurologists and neurosurgeons know the effect of all anesthetic drugs, so they also have fallen in love with the technique. You must also demonstrate to them the depth of anesthesia monitoring to show that otherwise they normally tend to blame you, saying that the brain may be too deep. So once again, just to reiterate, the use of depth of anesthesia monitoring doesn't matter what technique you're using and which monitor you use. This is a slide to show you that me and my student, Dr. Nimisha Thakur, we just did a study to compare and correlate the effects of the various mispositioning it, to see whether they correlate well or not. Because see what happens in neuroanesthesia and in neurosurgery, placement of this frontal lead sometimes can be very cumbersome, and the leads can get soaked with the dressing, with the cleansing solution, and during the operative procedure. So we have tried this. We tried this infraorbital approach, which worked fairly well. So why depth of anesthesia in anesthesia and neuroanesthesia? To protect against awareness and post-operative cognitive dysfunction, to preserve cognitive function, and to personalize and have more precision-based anesthesia. You can see this patient here in the recovery room, fully recovered, rapid recovery, faster response to verbal stimuli, and a faster discharge after daycare surgery. So tips and tricks for total intravenous anesthesia: have a dedicated line. Keep a watch on that IV line. So normally you have a special line for remifentanil only. Keep a vasopressor ready in the OT. Avoid boluses. Started during the pre-oxygenation. The maintenance infusion. A slight reduction in heart rate and blood pressure is expected. Watch out for severe bradycardia. After stopping the infusion, flush the IV line to avoid accidental flushing of the drug in recovery, and ensure bridging analgesia with a known opioid. I use paracetamol and NSAIDs alongside exactly towards the end of the surgery, so the patient has a smooth emergence. Another one quote for you, which I love: "For better to come, good must stand aside." Once again, now we have been using TCI TIVA, we have used TIVA, and now it's been used for many years. Now the next step is, why do we require a feedback loop? So I will just go quickly to this CLAD system, or closed loop anesthesia delivery. It's very important for us, even philosophically, to gather feedback, to analyze the feedback, and act on the insights and try to get better on a personal level as well as in your techniques which you're practicing. So why do you require the feedback? If you give too deep an anesthesia, you can get EEG suppression, which is the independent factor for post-operative delirium. You must hit it just right, because if it's too light, you can have increased incidence of intraoperative awareness, which you don't want. So now the NICE guidelines have said that, awareness, you must use a depth of anesthesia monitor in every patient. Unfortunately, it is still in India desirous and depending upon the availability. So I think one must incorporate it into routine practice to avoid both this too light and too deep a plane of anesthesia. So this is what I call the Goldilocks thing. Not too much, not too little, just right. In Swedish, they have a word called lagom, which means just the right dose. You have to touch it in the right dose. So here we come to this. Many people think that anesthesia and neuroanesthesia is like a something like an autopilot. You switch an autopilot and you fly it like an aircraft. I'm sorry, no, that's not the way it works. You have to be vigilant throughout the procedure, and you have to keep on changing your gears during the surgery. And so once you have this sort of system, like the closed loop anesthesia system, you have got the infusions going, you have got depth of anesthesia monitoring, and you have got a feedback loop that will increase and decrease the dose of the TCI and your syringe pumps. So it's an improved autopilot mode. It consists of continuous feedback of the physiological response of the patient to the surgical stimulus and the titration of anesthesia delivery. So the key components are sensors, monitors, algorithm controller, actuator and effector, and the feedback loop. So the goals are: we keep the patient in a physiological target range, reduce the variability within an individual patient, reduce the variability of care, encounter variation, provide variation and institutional variation, and we always strive to improve outcomes. So this is an excellent article done very long ago by Dr. G.D. Puri in PGI Chandigarh, closed loop anesthesia delivery system using bispectral index, a performance assessment study. And he actually moved on to getting his own pump, the world's first automated anesthesia delivery system, CLAD, patented by PGI Chandigarh. And these Clarity pumps are available. They are also relatively inexpensive for people who are starting off. So in case you need, if cost is an issue, you must explore this option. These are the various other systems available of a closed loop anesthesia system in anesthesia. To summarize, I think what we are all planning to do is precision-based neuroanesthesia, reduce drug use, improve safety, faster recovery, and reduce clinician burden. everybody compares us to airline pilots, and anesthesia is very often compared to, flying an aircraft. I will say aircrafts are complex, but human physiology is even more complex. AI and all these closed loops can modify what the physician anticipates. I only fear that use of too much of AI will decrease your native intelligence, like how we rely such a lot on Google Maps and we don't know how to drive along street roads in Bombay. So try to preserve your native intelligence while using AI wisely. So this is an interesting cartoon I just read today. Like, it will always give you a prompt that suits you. So the question is the mushroom edible? Yes. But after consuming the mushroom, the person has passed away, may his soul rest in peace. So he said, yes, the mushroom was poisonous. I'm sorry for the confusion. And would you like to know more about poisonous mushrooms? So the question that you ask AI and the feedback that you give AI is very important to get a specific answer. So moving forward, I think what we require is the synergy of technology and human care. So gentlemen and ladies, the light at the end of the tunnel is not an illusion. The tunnel is. So we think that we are moving to something better, but we are already there, and you must make sure that you utilize and convert all your dreams into a reality. So if you want a TCI pump, go ahead and get it. If you want to use depth of anesthesia monitoring, by all means, change your dreams into reality, get it and start using it. Thank you.
Thank you, Joseph, sir. It was really wonderful and involving talk. I request Dr. Kane ma'am to kindly give your valuable inputs.
Thank you. It was really, an insightful talk. I just wanted to ask you that, like you have said, that which BIS monitor are you using? Because I was looking at the values, and are you using the infrared?
No. So now, I am using both. But one monitor I got as a demo piece, but all these monitors are expensive. So what I've got integrated into my Philips monitor is a normal BIS strip. Okay. So see, let me also tell you, all the new incoming technologies are expensive, and we must be able to justify the use. And however, you must use it wisely. It doesn't matter whether you drive a Maruti or a Mercedes, as long as you reach that point A to point B. So don't get forced by industry to take expensive options. You move within your budget of your institution and in your practice.
That is also a BIS monitor only, madam. Now that
Yeah.
the Covidian is become Medtronic. So initially the Covidian company was taken over by Medtronic, but now the BIS is being sold as the Medtronic machine itself. It has, apart from the BIS, there is a DSA also, density spectral array comes. That's the same BIS monitor, standalone BIS monitor. However, cost has doubled from the BIS.
Yes.
That
That's
is
what.
always
No,
happening.
and even the charting is little different,
That
right?
is what,
So it
madam. That
comes.
is called as a density spectral array. That gives
Yes.
now the spectral edge frequency value and mean frequency value also along with the BIS number. That is adding more information to your what you are going to get it. According to the recent trends, what we are using the EEG monitor for measuring the depth of anesthesia.
And is that, have you ever seen that the BIS was within the anesthesia range, but yet you have seen awareness, sir?
Yeah, so now, see, let me also tell you that when you inject a drug and you're monitoring the BIS, there's a lag time. So sometimes you inject a small touch of propofol or you increase the dose. It takes 1 or 2 minutes for the BIS to fluctuate. So BIS is giving you a trend. It is not a number that you go by, but we tend to come to that 40 to 60 and try not to go too low. So, because I also noticed that going too low, you require those vasopressors, and of course, don't forget the problem of cognitive dysfunction in extremes of age in the elderly. Now, India is an aging population, so we get many patients who are extremely aged. So their requirements of anesthesia may be less. So I like to monitor all these things objectively, so I can demonstrate, madam. I can record in my sheet that the BIS was maintained between so and so. This is very important. I
Yes.
also the dose of the TCI and which model I'm using in my anesthesia notes. TCI
Yes.
elevated 1 nanogram, 2 nanogram. Just try and document it because
So
that
have
is
you seen a case of awareness?
No, no, I have not seen. I'm fortunate, I think.
Because the incidence of awareness itself is very low, madam.
Yeah.
And by large, the neurosurgery population is not a population which is high risk for awareness. So now the momentum shift is what we call is monitoring the consciousness. We don't say prevention of awareness anymore. So we are just monitoring the EVG or what is the conscious level of the patient.
All right. Thank you, sir. Thank you very much for it. And we can take some questions, I think.
Yeah.
Neha, will you?
Ma'am, can we take it at the end of the session because we are actually,
Okay.
I think, we still have the panel discussion to go on.
Yeah, okay. All right.
Thank you, ma'am. Thank you.
I hope I didn't rush too fast, but I tried to catch up in time.
No, sir. It was
very
really
informative and
engaging.
very concise, I
Very
must say. And
engaging,
you kept
actually.
all of us very engaged in that. Thank you so much.
Thank you, sir. Thank you, Joseph, sir. And thank you, Chinmay, sir. We'll move on without wasting any time for the panel discussion. I'm sharing my screen and I request Dr. Vandana, ma'am, to please introduce Dr. Bitkar, sir, and proceed ahead. Vandana, ma'am.
Yes. Can you hear me now?
Yes, ma'am.
Yeah. Thank you, Dr. Neha. With immense gratitude, I welcome Dr. Prasanna Bitkar, sir, to our panel discussion. He is professor in charge of neuroanesthesiology, Department of Anesthesia, ZIPMA. Sir holds the highest position as the president of Indian Society of Neuroanesthesia and Critical Care. Sir has made seminal contribution to literature by editing several books, including ACE Neurocare, Controversies in Neurocritical Care, and AWARE manuals. Despite an illustrious portfolio of over 125 national and international publications, he remains remarkably humble and grounded. A distinguished authority in neuroanesthesia, he has penned many chapters in neurology in various books. He has profound passion for all branches of neurology, though may be neuroanesthesia, neurocritical care, intra or post-op monitoring, or traumatic brain injury. So, on behalf of entire SAP and SAMS committee, I express our honor and privilege to have you as an esteemed panelist in our webinar, sir. Welcome, sir.
Thank you.
Yeah. Over to Dr. Neha.
Request Dr. Madhavi, ma'am, to introduce Dr. Katikar, ma'am, and Kanik, ma'am.
Thank you, Dr. Neha. It's my privilege to introduce our next panelist, Dr. Manisha Katikar, ma'am. She's a well-known anesthesiologist. She doesn't need much introduction. She's an anesthesiologist and intensivist at the Balwant Institute of Neurosurgery and Trauma in Solapur. Madam was former president, vice president, and editor of SAMS and GC ISA National. Welcome you, ma'am. Our next panelist is Dr. Hemangi Karnik, ma'am. Madam is a retired professor from LTMC Medical College, Mumbai. She has been practicing neuroanesthesia since past 3 decades. She has also guided many renowned neuroanesthesiologists and she has many publications and chapters to her credit. On behalf of SAP, I welcome you, ma'am. Over to Dr. Karne, sir, for panel discussion. Thank you.
Thank you, Dr. Madhvi. And I think we'll quickly begin with our case scenario. So we have a 28-year-old male brought to the emergency department after a high-speed traffic accident. On arrival, the airway is patent but unprotected. Patient is breathing at respiratory rate of 24 per minute with the SpO2 of 95% on face mask. Heart rate is around 110 plus, BP is 150/90, GCS is 10, E3, V3, M4, and pupils are bilaterally equal and reactive. Initial trauma evaluation, there is no associated major extracranial injury. CT scan shows there is a large left-sided subacute subdural hematoma with significant midline shift of approximately 8 millimeter, and there are early signs of uncal herniation. On clinical progression while the emergency, next slide please. The GCS, after 45 minutes, the GCS drops to 6 with E1, V1 and M4. Patient develops anisocoria with left pupil dilated and sluggish. There are episodes of bradycardia, heart rate hanging around 52 per minute with rising blood pressure. suggestive pushing response, and patient becomes increasingly agitated with intermittent posturing. The neurosurgical team decides for an emergency decompressive craniotomy for evacuation of hematoma. Patient arrives in OT. Patient is not yet intubated. BP of 170 by 100 millimeters of mercury. Heart rate is 55 per minute. SpO2 94% on oxygen. Suspected raised intracranial pressure, and patient is suspected to be full stomach. My question to you, Bidkar sir, how will we proceed with induction of anesthesia in this case while maintaining the hemodynamics?
Yeah, this patient actually needs to be intubated right in the casualty itself. When you see that somebody has got a 8 mm midline shift and an impending ankle herniation, there is no point that we should wait till the patient comes to the OT. Ideally, it should be done as soon as the scan is done, because this patient is likely to become, that's where the delay is there, and that patient might have got complicated. Okay, having said that, now the patient is complicated, comes to OT. So the injury has already happened, and there is a raised ICP now. So the first and foremost thing is to avoid the unnecessary secondary injuries. Okay. So what is these secondary injuries? One of the most important things are what we can anticipate. Generally, what we see during the post-induction is the hypotension. So the hypotension and hypercapnia are the one which are likely to cause more injury than as it is already has happened, the primary injury. These are the main cause of secondary injury. So then the next part is this, you are likely saying that the patient is maybe having a full stomach, then there is a risk of aspiration. So the ideal one, what the book quotes everywhere, is to do a rapid sequence induction. So if we go for an ideal rapid sequence induction, then we know that we are not supposed to ventilate. You give a drug and then you use a scoline. So there are two things here. If you do not ventilate this patient and you wait for 1 minute, say you are against scoline only, then the rise in CO2 itself can lead to again the rises in the ICP and thus enhancing the secondary injury. If at all, if you use a scoline, then there is a significant risk of raising ICP again, though it is transient, but still scoline still can cause. So now we have a better agent available. Most of the time, what we go for is a modified rapid sequence induction. In terms of we gently ventilate the patient using a Celix maneuver. So the pressures may be around less than 20 centimeters of water. Partial APL wall is closed. So we gently ventilate the patient so that there is no rise in the CO2. And the next is get a wide bore cannula and keep the fluid on flow so that, and the vasopressor ready to treat the hypotension. The third part is what you can use, because when you use an intubation technique, then what will you use? So the intubation response can accentuate the, again, increases in the ICP. You can, if you have a video laryngoscope, because these are the typical group of patients head injury where you cannot assess the airway. The patient is E1, V1, M4. We cannot assess, so we have to go by the Lemon law, except the Malampati, that how externally he looks and whether we can intubate. If the patient is very obese and all, so better to go for video laryngoscopy to minimize the intubation time and response also.
How will we select the drug for the induction?
Yeah, drug, you can use any drug. It is not an issue at all. So we have hardly 2-3 options. I don't know whether thiopentone is available in Maharashtra now. It is very difficult to find in most of the places of India. Now the propofol is the drug. So you can use judicious use of propofol if you feel that there are other injuries along with this. And the patient, if you feel that hypovolemic, then either you go for a intermediate or ketamine. Okay, if the patient is hypovolemic, even the ketamine also can cause the hypotension. Just keep a fluid on flow and use the drug judiciously. All three drugs have their own advantages and disadvantages. By far now, the propofol is still the most commonly used drug. In isolated head injuries, you do not expect a prolonged hypotension. So a transient can happen, which can be countered with some vasopressor, either a MEF or a phenylephrine can be used to elevate the BP post-induction.
Okay, thank you, sir. My question to, yes, ma'am,
may I add upon that? Yeah. This is a trauma case. So in trauma, we have to be little bit vigilant about what may be diagnosed and what may not yet be diagnosed. So on your first slide, I got 2 words. One was high speed. Patient suffered from the high speed accident. And second one was apparently no other injury. So that doesn't mean that there is no other injury. So we should have, all trauma patients, we must have high index of suspicion for any other unknown injury. So in these patients, what happens that when we try to give anesthesia just like the regular other patient, the response is different. So the same dose of propofol can cause severe hypotension, and even the regular dose in a hypovolemic patient can even be fatal. So we need to have high index of suspicion. We like to induce with the propofol because it is easy, safe for the brain, and we are used to it and all. But in hypovolemic patient, the hypotension needs to be kept in mind. So better alternative, as Dr. Prasanna said, is etomidate. Etomidate is available, and at least at our type of trauma centers and all. And when in doubt, even in a normovolemic patient, that would be a better thing to do, though at a cost, so that the people get used to using it when it is really required. Ketamine is acceptable when etomidate is not available. We were using it and all. But these patients most commonly are having severe tachycardia. And ketamine adds upon that, so much so that the even cardiac output may get affected. So because of that, we need to be cautious. Just because ketamine is available, because it can also be used for neurosurgery, it need not be used. The etomidate is better, but you need to have little bit dose adjustment when there is a hypovolemic, if even though you are using etomidate. So these things are there. And more importantly, which drug you are choosing. Rather than that, more important in trauma patient is how you use it, when you use it in that particular situation. So that would be important one for people to judge. Can we have a full screen for the slides, please?
Yeah.
And
Yes.
the computer through which the screen is being shared needs to be charged. Put for charging, it is getting over. Yeah, thank you.
Can I add something? Dr. Karani, can I add something?
Yes,
I'm audible?
Yes, madam, you are audible. Please go ahead.
For anyone who sees this patient in emergency department, before the GCS drops, it is very important to manage the airway, breathing, and circulation in such kind of patients. I feel if we as anesthesiologists see such kind of patient in a casualty or in an emergency department, we should act rapidly to have a control over airway. The CT scan can be done later on, but the airway should be controlled rapidly with whatever techniques sir has mentioned. Airway should be given, the ABC has to be given prime importance in head injury patients. That's what I feel.
Can you also add about role of ketamine in the revised role of ketamine in neuroanesthesia?
So, Vikas,
yes, sir.
Let me add to this. So, Dr. Prasanna has covered the topic very well, and nice to hear Dr. Himangi Karnik also. But I like to add another point. There were all the points that you made. Cervical spine control. So till you prove that the cervical spine has been cleared, you must put a hard collar on. Now the hard collar on, there's no option. It's a Philadelphia hard collar. So it's very important, and the patient should be on a spine board. The other thing I would like to say is etomidate. Since you can use whatever you want, but for if there are any students in the audience, then etomidate, keeping in mind the fact that it can cause adrenal suppression. If the patient is hemodynamically unstable and the pressures are low, then use 0.2 milligram per kg as per the ETLS protocol. And if the patient is hemodynamically stable and relatively well preserved hemodynamically, you can use 0.3 milligram per kg, keeping in mind the possible chance of even a single shot of etomidate causing this adrenal suppression. Now, I also want to say ketamine is a much maligned drug. Ketamine is being used in so many ways. So he has become not a friend, not a foe anymore, neither a friend, maybe a friend. It's a mixture of friend and enemy. This term I've learned from my daughters. So he may be looking like a friend, but he may still be an enemy. Okay, you should use it wisely. So if you use a small dose, very often you can use it in a small dose as an infusion. And for induction, See, don't see whatever we may say in the periphery. I'm sure people are using ketamine to maintain hemodynamic stability. All the other drugs may have some effect on the hemodynamics, and we all know that our aim in neuroanesthesia is to maintain the perfusion pressure of the spine and the brain. So you choose which drug. It doesn't matter which drug, but whatever you use it well.
So in short, we should be, using the drug which we are used to handle, where we can predict the response.
And which you have in your practice in your institution. So if I tell you some very rare drug, you may not have it. So I must tell you something practical in your setup.
So rather than using something which we are not using routinely and probably inviting more complications, we should stick to what we are using, where we understand the drug in and out.
Yeah.
So
I think we are using propofol day in and day out, and all of us are, see, this kind of patients we do not get at the corporate hospital. We may get it at the peripheral hospital also. So we are all used to use propofol. So propofol can be used judiciously, very slowly in such kind of patients by maintaining the hemodynamic stability. I feel propofol is the best drug in such situation. And as Joseph sir said, definitely we can add, if required, ketamine, small dose, but if required. And Madam also mentioned that such patients is having gross tachycardia. So we have to judge and individualize depending upon the patient's clinical situation.
So though Dr. Bidkar sir has already mentioned that we can use vasopressors if required, but looking at the scenario that we discussed at the time of induction, in spite of all the precautions, if pressure starts dropping, then what vasopressors and how would you choose? And do we really rush for the invasive monitoring in such situations where patient is deteriorating hemodynamically? So ultimately, what I mean to ask is how we prioritize cerebral perfusion pressure when the hemodynamics are getting compromised.
Yeah, yes, somehow you have to maintain it. That's the crux of it. You can use whatever you want, either adrenaline, noradrenaline. Noradrenaline is now the darling of everybody. So everybody wants to use a noradrenaline immediately. First and most important thing is the fluid replacement. So you have a 2 wide bore cannula, and if you are anticipating, get the central line in place before handing it over to the surgeon. Here the hypotension is not only before, because the ICP is quite high, rather than finding hypotension immediately after induction, generally you find it when the bone flap is raised. There will be severe blood loss also, brain will bulge, and sudden decompression leads to refractory hypotension. So if your tank is full, then you can whip the horse so that it starts functioning. If the tank is not full, then you cannot whip the horse. So it's always better to have the this fluid replacement proper so that the intravascular volume is correct. Then you start noradrenaline, and then it becomes an entirely different scenario, because from the situation of maintaining the hemodynamics, we will be entering into a situation of resuscitation. There will be ongoing blood loss if the surgery has started and bone flap is placed. And so you have to have multiple scenarios, like you just try to maintain both because you have already given a 30-degree head and elevation for the surgery. Now the hypotension is there, whether you want to reduce it. A lot of calls you have to take. Somehow you have to try to maintain the hemodynamics. It is tough, and sometimes it will happen that it will not respond also, but you have to try to get it as soon as possible. The prolonged periods of hypotension are more dangerous, so you get it back.
So we are saying that we should optimize the fluids when the decompression is happening. At the same time, try and replace the blood if it is needed, and have some vasopressors ready or probably online. Patika madam would like to add anything to this?
Particularly, rather than noradrenaline infusion, which takes few minutes to prepare, I generally keep the phenylephrine, Fenpress LS, that is available in the low strength, and it's ready to aspirate and give. So that can be used in within seconds. So the moment hypotension occurs, you just aspirate and give short doses and all. And the principle over here is to keep the hypotension to the minimum. The severity also should be minimum, and the duration of the hypotension also should be kept minimum to minimize the secondary injury to the brain. So here that Fenpress, immediately given some 10 microgram Aliquots and all, really helps. And by that time, you tell somebody to prepare noradrenaline infusion and all. And if the blood pressure doesn't come back again, if it is blood loss, it will take some time because the fluid needs to go and all. But if it is just because of the secondary to the propofol or a sudden decompression, probably it will be transient, and even the Fenpress alone would be sufficient. So that becomes practically very useful. So by the time you are preparing the infusion, it is treated. So that's what I particularly.
Yeah. So Vikas, just let me. So most of it is covered, but I feel, see, one must always objectify the choice of the drug. So if I've got an arterial line in place, then I use pulse pressure variation. It tells you whether the patient is fluid responsive. Now, when we're talking of this trauma case, A, B, C, circulation always goes with hemorrhage control. Otherwise, it's like pouring fluids in a bucket that is draining water. So it doesn't have any sense. Doesn't make sense using vasopressors in such a scenario then. So after you have achieved hemorrhage control, and then you're taking up a choice of a vasopressor. Now, I think with this focus coming along, I like to have a look at the contractility of the heart. If the contractility is good, then I may go for phenylephrine. If the contractility is not good, because then if you use phenylephrine with the heart does not contract, you're only increasing the afterload and you're not going to have so much purpose. So if the contractility is not good, then I'll go for norepinephrine. So Prasanna said, actually norepinephrine is the favorite. So if you even that way, you will not go wrong. If you use noradrenaline, you may not go wrong. If you use phenylephrine in a failing heart, it may not be a good idea. So, but if you can do a quick parasternal view or at least a subxiphoid view of the heart and see the chambers contracting, then I will choose my drug better.
So you're suggesting that
use phenylephrine,
possible, we should make, sir,
in neurogenic shock.
So you're suggesting that possible.
See, Vikas, if everything is available, we can definitely go for that. But with the case which you have described, a GCS dropping to 6, and there is a gross midline shift of 8 mm. Everywhere, every time, we may not get help as well as time to do all these kind of things. I agree with Karnik madam. If there is a significant hypotension after opening of dura, which definitely happens because to control the pressure responses at the time of intubation, we have given a lot of propofol, maybe dexmedetomidine. And as soon as the bone flap is raised and the dura is open, there is significant hypotension. Why we are worried about hypotension in
think we
We have
lost
lost your
madam.
voice, madam.
Yeah.
audible?
Yes,
Yeah,
ma'am.
Yeah. So to maintain that cerebral perfusion pressure, we do not want hypertension because that will affect, again, it will cause the cerebral ischemia. So that is why we are worried about the hypotension. And that hypotension has to be corrected immediately. And clinically, if we see, small or minor doses of phenylephrine may be given in the doses of 1 or 1.5 cc definitely will improve the mean arterial pressure and will not cause that much significant, will not affect contractility of the heart. So practically, if we are managing such kind of cases, maybe noradrenaline will be prepared later on by someone, but we have to counteract that hypotension immediately at that moment only, and phenylephrine wonderfully helps in smaller doses in such situations. I agree with Himangi madam in that situation.
Okay. Dr. Chinmay, in this particular case, what will be our agent of choice for the maintenance of anesthesia? Will we use volatiles or we would like to go for the propofol as a prophylactic intravenous?
So my agent of choice would be volatile anesthetic agent, primarily up to 1 Mac. Then if the pressures are still on the higher side, only then I will start propofol. Volatile anesthetic agent, sevoflurane less than 1 Mac, oxygen air concentration 50-50%, provided the saturation is maintained above 90-92%. Then infusion of muscle relaxant and infusion of opioid, I would prefer fentanyl.
Okay.
Propofol only if pressures are still higher, despite using up to 1 Mac of inhalation agent. Only then I used propofol infusion.
In this particular case, when the ICP appears to be on higher side, will there be any advantage of using TIVA against volatiles?
I have not used TIVA in emergency situations.
Any inputs, Bidgar sir?
I always try to prefer balanced anesthesia using inhalational and intravenous.
Always TIVA is better.
Yeah,
Absolutely.
always TIVA will be preferred.
TIVA is better,
Especially
absolutely.
nitrous oxide should be avoided when there is an obvious deterioration because of raised ICP. And sevoflurane or any other inhalational, when it is to be used, it should be used in smaller doses. So fentanyl or nowadays, if available, remifentanil along with propofol will be on one side, and then additionally we can use inhalational if required.
Just
Otherwise,
titrate
TIVA.
judiciously and use TIVA.
Otherwise, TIVA is
When there is a raised ICP, even a 1 MAC, less than 1 MAC of sevoflurane, I don't think it is wise to use.
Yes.
So once the decompression is done and all, then it's a different issue when the ICP is reduced or a decompression is done, hematoma is removed, you feel brain is lax, then what agent you use does not matter. But in the initial phases, yes, there is a risk of hypotension which needs to be avoided. People tend to feel that using nitrous and sevoflurane will give less hypotension and all. And the hypertension, we will not treat that aggressively also, that to bring it to 100, 110, because that may be a compensatory mechanism which is happening. We will not that reduce aggressively. But once the brain, he feels above the dura and he tells what is the status, then we can, what agent we use does not matter. But if the brain is tense, if the ICP is raised, it's always better to go for a TIVA. But one of the studies we published also where TIVA appears to be better.
Okay.
Yes, absolutely agree.
Many of
Absolutely agree with Prasanna.
Even in the many of the countries, even for elective cases everywhere, the TIVA is the choice for neuroanesthesia.
Yes, yes.
But here we use because we tend to use it. Nitrous oxide, I am not sure whether somebody is using in neuroanesthesia. We have stopped it long back. In fact, in other OTs also, our residents are not willing to use nitrous now. It's been ages I have used nitrous oxide. But are you using nitrous, Chinmay?
No, not at all.
Okay, so
I think that's the story everywhere, because even in our hospital now we are nitrous oxide free hospital. We have with all oxygen and air. We don't even have the the supply of the nitrous oxide for the OTs.
Yes.
A lot of corporate hospital now they are not putting nitrous lines also. They just don't want to put it.
But many of the peripheral hospitals still do not have the air pipeline and all, and people are dependent on nitrous oxide. So nitrous is not a bad drug, but when option is available of avoiding nitrous, then you can go in for a better one and TIVA and all. But however, if the ICP is not raised, if the patient is stable, nitrous oxide is not that means it provides stable anesthesia, and for years we have used it. So people should not be afraid of that, but when not to use it, people should remember, especially in trauma patient, when there is a pneumocephalus and all, especially and all, we need to keep that in mind.
And if we are using nitrous oxide, maybe we can use the concentration as low as possible just to avoid 100% FiO2, rather than using it as a...
No.
In those institutes, peripheral hospital where air is not allowed.
Lower concentration of nitrous oxide with TIVA is fine.
Yes.
Even a lower concentration of nitrous oxide with inhalational is not advisable.
Right.
Particularly in this. Okay.
So in this particular case, Monteiro sir, how do we define our approach after decompression? The surgeon complains that brain is still tight. So how we approach, and what are the modalities that we can use?
Normally, I don't use inhalational agents for these patients. So, and let me tell you one thing, there are two types of trespass. One is a surgical trespass, one is an anesthetic trespass. The anesthetic trespass is a physiological trespass. Most of us, if we practice the normal good principles of neuroanesthesia, there will be not much of a anesthetic trespass. So there's very little you can do in terms of an anesthetic technique. But if somebody is using an inhalational based technique, then that person makes sense to switch over to TIVA. Okay. Now, is the brain still tight beyond you have done your best? Then the only thing I think will be something surgical that you may have to do. Do you agree, Prasanna?
Yes, sir. See, here
Yeah.
again go back to the basics.
Yeah.
Also, tier 0, tier 1, tier 2, tier 3.
Yes.
Yeah, just go back, give a slight head and elevation, see whether the
That
jugular, this one is drainage is proper or not. See whether there are any convulsions happening, give anti-epileptics if you need. If fever is there, treat it. Okay, if too much hypertension is there, try to bring it down. And then go for, you can give additional dose of mannitol or hypertonic saline, whichever you prefer. The mannitol one works better. That's what conventionally we use mannitol here. Then you can transiently do a hyperventilation to reduce and see whether it will relax the brain. You can do a transient hyperventilation. If that also not subsiding, many a times it happens that you are absolutely not able to close the dura nor even the skin flap. Okay, that is the time when you can even go for a barbiturate coma, and you just leave the temperature. Don't actively try to warm the patient, just leave for a mild or moderate hypothermia. But best is to go for a either a propofol induced deeper anesthesia burst suppression or a thiopentone. If it is available, you can go for a barbiturate coma with avoiding hypotension as the rider. And despite this also, in a few of the cases it happens that brain will not settle down. These are the cases, nothing much, even the God can't do anything in this. That's the fate is sealed. But with these features and all, it can be tried this phase 1, 2, 3 manner. Every time you have to go back to the basics and rule out all the possible. Because many times what happens is brain bulge, you have to have a high index of suspicion, maybe due to a contralateral EDH. When you decompress here, a small EDH is there on the opposite side increases. That pushes the brain out. You need to have a high index of suspicion of that also. And you see the scan in the pre-op itself, and that may also happen. Okay, so that also you should keep in mind that these are all the possibilities which can happen in the intraoperative.
So, doctor, so because if your question was directed towards whether the choice of the hyperosmolar agent,
Yes.
then in traumatic brain injury, they suggest because the blood-brain barrier may be disrupted, then you can use hypertonic saline. But then routine practice, most practice all over is the use of mannitol. Maybe is easily available, but you can use hypertonic saline 3% if you want. But the point is, I think prophylactic use of these hyperosmolar agents is not advised.
Okay. So unless we land up in a situation where everything else is probably falling
Yeah.
apart, then probably we can use. And we all are suggesting that
Already brain bulge is there. No, already brain bulge is there.
Yes.
ICP range there. Impending uncle herniation is there. Enough indication to use mannitol.
And in spite of whatever measures you take, in this kind of large STH, whatever you use, the moment incision is put on the dura, the blood clot will come out with the positive pressure. None of your techniques will fail. So our aim is to reduce the ICP, but still the clot will come out of its own and then it will come out. It will pout out. The principle is not to allow brain to pout out. So that is why we take all these things. Another thing is the initial CT scan that has been done in this case will not show contusion. Whereas with this kind of injury, the contusion is common, but it will not be visible in the first CT scan. It will take some 24 hours or so to be visible. So we need to have, as Dr. Prasanna said, we need to keep in mind the other injury which we have still not diagnosed, either the contralateral or the contusion. So that itself will affect our post-operative management as well.
Okay. Katika madam.
Small dose of diuretic like a furosemide will also help to decrease the ICP in such situations.
Madam, any comment on how we should use hyperventilation in this situation? How long we can use that? Because prolonged hyperventilation can also cause cerebral ischemia. So what is your take on that?
Yeah, if we are planning, so if there is a tense brain which is not getting relieved by whatever drugs, inhalation, and sorry, not inhalation, intravenous agents you are using, you have to give brief episodes of hyperventilation. You have to see that you are monitoring the end-tidal CO2. You have to see that your end-tidal CO2 do not fall very low, below 30 or maybe below 28 or millimeters of mercury. This is because if there is a significant fall in end-tidal CO2, it will again cause cerebral ischemia. So brief periods of hypoventilation with normoventilation for some time, and then again brief periods of hyperventilation will help in controlling the ICP in such situations. So along with other measures, brief hyperventilation should be introduced immediately as soon as you see that the brain is tense and the surgeon is asking for your help. You have to do so many things together at that time. If you have started an inhalational, switch off that, continue with intravenous agents, give additional doses of mannitol, give additional doses of diuretics at that time, and at the same time, start hyperventilating the patient, looking at the end tidal CO2. So that's so many things you have to do in a span of maybe 3 to 5 minutes.
What would be our target ETCO2 in case if we decide to hyperventilate, and how long would we do that?
Yeah, I said brief. Brief means the target ETCO2 ideally should not go below 30, not ETCO2, the PCO2 should not go below 30 millimeters of mercury. So that should be the value, 28 to 30 millimeters of mercury, PCO2 levels that should be maintained. So that we have to follow, because we do not want, if the end tidal CO2 or the PCO2 starts falling below 25 millimeters of mercury, the cerebral ischemia may occur. So we have to avoid that.
One more thing in these cases, what happens sometimes, these patients like this typical what the history you gave, these patients are not intubated full stomach in the emergency. So they might have aspirated. So the actual PaCO2 may be very high. The EtCO2 may show low. There is a shunt which happened because of the aspiration. So these are the ideal cases where you should get the ABG done if you have a suspicion. Better to get the ABG done, because nowadays I see that resident, they do some 5 to 10 ABG for every case, baseline after 1 hour, after 2 hours, in the elective cases where it is not indicated. But these are the group of patients which I feel that better to get, because it will give multiple information, PCO2, PO2, status of the lung, and also the HB, lactate, so many things you will get. So I think
Metabolic acidosis also,
yes,
which we will also. Yeah, but if there is a hypertension, then associated metabolic acidosis.
so many information you get, it's better to get an ABG done also to look at this.
No, because let me also add one point that prophylactic hyperventilation should be avoided.
Yes.
Yes or no? So this is a normal practice. Neuro ka case hai, chalo, the patient will be furiously and enthusiastically moving the patient. That can also cause decrease in the cardiac output. It can cause cardiac tamponade because of the overinflated lungs. And if you reduce the PaCO2 too much, you may harm a compromised brain. It may cause cerebral vasoconstriction and cause increased damage to a part of the brain which you don't want to damage. So prophylactic and over-enthusiastic hyperventilation should be avoided unless you are monitoring it if it is ETCO2.
So the take-home message is normoventilation in all other situations.
Unless it is mandated by tight brain where a brief hyperventilation can be provided, but a red flag should be there that it may lead to the secondary injury. It itself can lead to the secondary injury. So, Montre sir, in this particular case, how do we decide whether we are going to attempt extubation in this particular case, because neurosurgeons will keep on, pressurizing that we want to do the neuromonitoring, or we will go for elective ventilation. So, how do we decide in which cases we go for elective ventilation, on which cases we, attempt an extubation?
No, this very patient I will not extubate. So it is non-negotiable. The patient will go on the ventilator. He will be ventilated, sedated, ventilated at least overnight.
Yes.
And we'll reassess the patient the next day. There is no question of extubating. Prasanna?
Yes, absolutely, sir.
Yeah.
Most of the cases, only cases where you can attempt extubation in neurosurgery trauma are the depressed fractures, where it becomes patient is full GCS, uneventful. Even a EDH with this GCS of even M4 cannot be extubated. Generally, what everybody feels that is M4, the moment you take out the hematoma, he will become M6. That's a general perception. It will not happen. It will take time for the brain to recover. Always put on ventilation, assess on the next day, put him on sedation. Next day you assess, get the post-op CT done, see how is the CT, what is the state, whether there is a still raised ICP features are there. Okay, then you may have to continue the sedation for further some more time with anti-edema measures. If nothing is there, CT looks fine, then you assess the GCS. If the GCS is improving, at least patient must be M5 to attempt the extubation.
So it is safer to keep the patient on ventilator, allow the brain to recover.
It is mandatory to keep, not safer.
Absolutely
It is mandatory.
mandatory.
Yes, this patient has to be ventilated, electively
He has already
ventilated.
suffered from the injury,
Yeah.
pre-op deteriorated. Secondary injury, herniation has taken place. There is no doubt.
One thing we should remember in neuroanesthesia or neurosurgery, neurosciences, the best neurological recovery is only possible when the patient is M6 and you pick him up when he becomes weak M6.
Yes.
Okay.
Yes, absolutely.
M4 means residual neurological deficit is going to be there. Okay, so you have to go on ventilator. That's it. So that's why taking early golden hour is the one which matters more.
You have simplified it in a very much. I asked that particular question because in smaller centers where these surgeries are happening very often now, anesthetists always remain in dilemma what they should do. And I think we are giving them a very clear message that ventilate the patient, let the brain recover, let the physiology settle down, and then only we can,
Yes, yes. See, and a patient with such kind of GCS may need elective ventilation for more than 48 to 72 hours also. It will all depend upon his neurological recovery. So if you extubate him on table, first thing, he will not breathe properly. You are creating more harm, neurological harm in such situations. So avoid everything, just selectively ventilate. Do not give any reversal agent. Shift the patient from the OT on the ventilator in the neuro ICU. And if that peripheral hospital, if it doesn't have such kind of facilities, then such kind of cases should not be done in that situation.
Right.
So that should be again a bottom line in such cases.
That's where, because they want, there is no ventilator available or the cost is too high. These are the primary reasons why. Well, so what is the safer approach is that you shift a ventilator first 24 hours, observe. If you feel that recovery is going to take long, you do early tracheostomy, wean him off from the ventilator. Once the brain CT looks okay, that is fine. Shift him to only high dependence unit or whatever, but not extubating on table. It is not possible.
I think as we move ahead, I just have one last question. I'm just tricking the situation. This particular patient is not having such a gross drop in the GCS. He's stable. There is no change in the CT in next 24 hours, but there is an associated fracture femur. So orthopedic surgeon is pushing now for early orthopedic fixation, at least a temporary fixation. So my last two questions: how do we define when we can go ahead with that surgery? And what is the take on at least external fixators versus a definitive orthopedic surgery? So how we decide which is better and how we go about it? How we decide when we can operate that particular patient? For orthopedic, neurosurgeon is saying we are going conservative in this particular case.
So who's taking this question? So anyway, I'll say. No. So one thing, I'll tell you one thing. In order to deal with this question, you have to have excellent communicative skills and very good to deal with the surgeon first. So whoever be the surgeon, I think there's a thing called damage control orthopedics.
Yes.
So that procedure can be done after 48 hours. In the first immediate part, in the first few hours, you can have to put an external fixator, do a debridement, stabilize the fracture, and get some hemorrhage control. Beyond that, you can't achieve much. If you want to do a definitive procedure like a intermedullary nailing or whatever, you can do it after 48 hours. So there also, I think you should be a little strict. And see, there are other things you have to see. You can see the type of fracture that you've got. If it's an associated pelvic fracture, then obviously you cannot handle that case within the first 48 hours. See the associated injuries, see the hemodynamic stability of the patient. And if you have got better monitoring, then you see lactates, you can see interleukin 6 and all those things which may not be available. Anyway, but basically, I think I wait for 48 hours. Because sometimes I tell you, the CT scan may, even if there's diffuse axonal injury, it may underestimate the injury to the brain. Right. So you may not be aware of the amount of cerebral edema present. So it's better to wait for some time and then reassess the patient. Prasanna, what do you say?
Absolutely.
Yes, sir, absolutely. See, the orthopedic surgeons just looks at the bone. The neurosurgeon looks at the brain. But here we are the resuscitators. We, the trauma anesthesiologists or the trauma intensivists, has to take the lead. we had to decide which surgery has to be prioritized, which has to be operated first. So it is us, the anesthesiologists, who are managing these such cases in ICU as well as OT, will take that call that we will not operate this case first. We will go for neurosurgery, or we'll go or fix this kind of. We will do we'll practice damage control orthopedics for the fracture, associated fracture. So we should take lead, as Dr. Joseph said correctly. We need to have good communicative skills in such kind of situations. We have to convince the neurosurgeons as well as orthopedic surgeons, and we have to take lead in managing such kind of situations if there is an associated orthopedic injury.
So at least 48 hours, that is what we are agreeing upon.
Yeah.
So anytime, irrespective of what neurosurgeons say or whether they are operating or not operating, anytime if the GCS is less than 14, even for a short time, or any CT scan report which is not normal, showing any abnormality, are to be considered as positive for head injury, and any non-emergency surgery, which is not a life-saving surgery, should be deferred by 24 to 48 hours. Only life-threatening emergencies like blunt abdomen for exploration and all probably will have to take place, and then that special consent and everything needs to be taken. So closed fractures, even though orthopedic surgeons are after us, these are to be treated as the emergency head injury cases and need to be deferred for 48 hours. After 24 hours, we need to repeat the CT scan, see how much is the head injury evolved, whether it has progressed further or no. If progressed, probably the patient may have to be operated for the neurosurgery first, and then further orthopedic surgery may have to be deferred. Otherwise, if it is not progressing, if patient is stable, then after 48 hours, we can take the patient for orthopedic surgery, but with all neurosurgical principles.
So I think with this, I think can we move on to the few questions which are there in the chat box before we end this session? So there's one question. This could not be applied in case of surgical site interrupted. So what do we do then? I think Mundul sir has already shown that how we can do that.
Other alternative is occipital, the placement is also tried, and that also shows, but how reliable it will be, it is again experimentally tried and it can be used. So that is another thing.
One comment. As long as the lead 3, that is the BIS lead, is in front of the tragus, then whether you put it this way, whether you put it this way, whether you put it this way, all are documented, all are studied. But the lead 3, that is the lead that monitors the BIS, should be in front of the tragus.
I think
so if there is a bifrontal craniotomy, then only in that situation sometimes it creates problem. But otherwise, in other cases, most of the cases, I think there should not be any issue.
I think Dr. Chinmay has certainly given a good lead in this particular situation, focusing on the lead 3. Another question is, when we discontinue remifentanil infusion at the end of surgery, when do we administer NSAIDs or paracetamol?
No, can you tell us again the question?
When we discontinue remifentanil infusion at the end of the surgery, at what time we administer NSAIDs or paracetamol?
So I give it about half an hour before the end.
Absolutely.
Half an hour before the end.
To avoid
and if the pins are on, I keep the remifentanil at 1 nanogram per ml until the pin removal. And then I know that it will take 6 minutes. So that gives you a smooth transition.
Okay.
For NSAIDs, diclofenac, I check the creatinine to make sure it is normal. Nothing is a routine. So that way the safety profile of paracetamol is the best.
Yes. Next
Will you
question.
do bolus of propofol, sir?
See, we haven't, I think we haven't
Bolus
discussed
of
about...
fentanyl, sorry. Fentanyl.
Yeah, you
Bolus
can
of
use
fentanyl
any drug, fentanyl, morphine. You just
prior
time.
to stopping remifentanil.
In one of the studies that we conducted, we used fentanyl before stopping the remifentanil infusion, and really gave us more stable analgesic condition post-operatively.
Vikas,
when
just
we
to
did
add
that,
what everyone has said, Vikas, just wanted
Yes,
to
ma'am.
add, we haven't discussed about skull block, which
Hmm.
is very useful in neurosurgery. In fact, that it definitely decreases the doses of fentanyl, propofol that is required for maintenance of anesthesia, and it definitely gives good post-operative pain control also. So you need not hurry for giving paracetamol also. So skull block is the easiest regional anesthesia in neuroanesthesia. So that can be practiced in any kind of whether it's a traumatic brain injury or elective neurosurgical case. So I think that should be emphasized to all the practitioners, whether they are practicing in periphery or in corporate hospitals, that they should develop the technique of giving skull blocks in
They must
neurosurgery
know.
patients.
And it should be preempt.
Agree.
So after induction, it should be given so that before
Yes,
incident,
yes,
the
yes.
block is active.
Yeah,
post-op also prior to extubation you can give.
Yes. There's
Yeah.
one more question. This is to Monter sir. Sir, do you give?
Vikas, can I leave the meeting, please?
Yes, ma'am. Yes,
Can I
ma'am.
leave
Please. Thank you
because
so much. I know we
yeah,
are in
thank you so
transit
much.
and thank you for joining us. We have last two
Thank you.
questions.
Thanks a lot.
Okay.
Thanks
Bye,
for giving me
Manisha.
opportunity.
Thank you.
Bye, madam. Bye,
Bye.
madam.
Bye.
Thank you, ma'am. Thank you. Bye. Bye, sir. Bidkar, sir.
Yeah.
So, yeah, last question, sir. Do you give inhalation agents along with remifentanil for neuro cases, or it is only propofol and remifentanil as a team up?
No, depending upon the availability, when we did not have remifentanil, and we used to use inhalational agents and fentanyl too. It's only now that we have got it that I have switched over to this remifentanil based technique. I found also that the use of remifentanil has decreased my propofol requirement.
Okay.
Absolutely. It reduces significant
Yes.
amount of propofol usage. And in that way, it is really good, particularly when you have IONM along with that.
Yes.
That's wonder drug. Absolutely no.
And it gives more stable hemodynamics intraoperatively and excellent recovery.
Yes.
The last question is, how do we diagnose neurogenic cardiomyopathy? What is the prognosis and how will you manage it? Anyway.
Prasanna?
Yeah, this all this cardiomyopathy and all, see, this it depends on the case, what has come, and it's all exclusion only. You cannot say because when the catecholamine surge is there, you will have a lot of say on ST changes. There may be regional wall motion abnormalities. There can be that syndrome. What is that syndrome? Like octopus like
Takotsubo.
cardiomyopathy and all. It's all high index of suspicion and treat accordingly. You do echo done and treat it accordingly. So it's all exclusion because you can't do much there. You exclude other causes and then come to this clause. That's
I think echocardiography is the way forward. If you make so you can make on echocardiography if you want to make a diagnosis. But to pinpoint that it is neurogenic in nature may be difficult.
Yeah, exactly. Diagnosis will require an expert to do the echo. However, as an anesthesiologist, we can do just 4 views of FET in the ICU or in the emergency room itself. And with the minimum training, we can identify that at least whether the heart is contracting normally or it is reduced. That much we have routinely started practicing in our trauma ward as well as in the neuro ICU also. And we have diagnosed cardiomyopathy in several of the patients. It is common in the head injury patients when the ICP is severely raised, and also is very commonly seen with the subarachnoid hemorrhage patients. So transient reduction in the cardiac function is seen commonly even in the postpartum patients also. It is routinely done in our institution by the anesthesiologist. We don't have the exact diagnosis or the regional wall motion and all, but at least roughly we can say whether heart is contracting properly or no. And our residents are able to identify whether it has deteriorated or it has come back. For subarachnoid hemorrhage patients, we have had chance of following up in multiple ways, multiple days and all. And we have found that once the ICP is reduced, once the basic pathology is corrected, it is reversible, including the Takotsubo type. And the patient can recover very well. And the earliest recovery we have seen is within 1 week. So just because there is cardiomyopathy, we should not be hurrying about or worrying about that. We have to take care of the ICP, ensure that the ICP and the neurological status is well controlled, and then gradually the heart may recover itself. Of course, this may not be true for all cases, but we need to keep that in mind, and it has happened.
Thank you, madam, and thank you, everyone. I think the time is running, and before we go for the vote of thanks from Dr. Sumedha, I'll request Kane madam and Sardesai madam to give their suggestions or inputs.
Thank you for inviting Dr. Karne. Thank you.
Thank you. It was a pleasure to have you all. It was wonderful talking to you.
Yeah,
it was our pleasure.
It was a wonderful webinar, and you have covered almost all aspects of neuroanesthesia. Just I want to ask about the DSA. Really, it is useful, used in many neuro centers?
Yes.
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 And it has upper hand over the all other monitors, I think, EEG, BIS and entropy.
Every monitor you use, it is how you interpret it. So the more you use it, the more information you'll be able to extract, and then it will be more beneficial to you. So if you want to only see depth of anesthesia, then that BIS strip is sufficient. But as you go deeper into the subject and then use DSA, then you can study more. You can get the patterns of all the agents. You can study the pattern of burst suppression. You can see the pattern of volatile versus IV, and you can see at the end of the emergence how when you switch off the drugs, how that landscape pattern on the map changes. So those things will be very interesting, and the more you use it, the more useful it will be. However, if you don't have it, then if you're just looking at only one single number, the depth of anesthesia, then but the more you use it, the better it will be.
Okay.
DSA is nothing but it is measuring the alpha, beta, theta, delta activity, madam. Based on that, it will give a 2D spectrogram, color spectrogram, to make you understand easier. It is more like reading the EEG than actually relying on the number. So in future, it is going to come in academics of anesthesia that every anesthetist should know EEG monitoring. Like how we tell every anesthetist should be trained in depth of anesthesia monitoring and TCI. In future, it will come like every anesthetist should know the basics of EEG. So that is the future. Apart from that, it will give that spectral edge frequency value also based on that. So they are all a good indicator of using them. It's not a...
Okay. Thank you. Yeah.
Thank you, Dr. Karne. The panel discussion was very, very interesting. And I'm sure all the people who are listening will definitely benefit.
Yeah, definitely.
Thank you.
Thank you.
Thank you and good night.
Dr. Sumedha?
Yes. Good evening, everyone. It is my privilege to propose vote of thanks. On behalf of SAP, I extend my sincere gratitude to SAP Office Bearer Dr. Avinash Bhosle, President, Dr. Sheetal Dalal, Honorary Secretary, Dr. Vikas Kanne, Vice President, and all esteemed office bearer for providing this platform and for their constant support and encouragement in organizing this webinar, as well as various SAP activities. I would like to express my heartfelt thanks to our esteemed chairperson, Dr. Kane ma'am, and our distinguished speaker, Dr. Monterio sir, and Dr. Bhave sir, for sharing their invaluable knowledge and insights in the field of neuroanesthesia. As rightly said, knowledge shared is knowledge multiplied. Sirs, your profound wisdom has truly deepened our understanding and will continue to guide us in our clinical practice in the future. I also extend my sincere gratitude to our esteemed panelists, Dr. Katikar ma'am, Dr. Vitkar sir, Dr. Karnik ma'am, and Dr. Monterio sir for their expert guidance and practical wisdom and insightful clinical perspectives that greatly enriched today's case discussion. I convey my special thanks to Dr. Sardesai ma'am, President SAP, and Dr. Vikas Kanne sir, Vice President SAMS, for their vision, meticulous planning, and excellent execution of this webinar. I would also like to thank Mr. Ganesh for his technical support, ensuring the smooth conduct of this session. Last but not least, I express my heartfelt thanks to our wonderful audience for their participation and making this webinar a success. With this, I conclude. Thank you all. Thank you, sir.
Thank you. Thank you,
Thank you,
everyone,
everyone.
once again.
Like,
Thank you, Karne
Thank you,
sir.
audience.
Thank you, Kane madam.
Sir,
Thank you
thank
all.
you. Bhavya sir,
Thank
thank
you.
you.
And good night to everyone.
Kani madam, thank you.
Night.
Thank
Kane
you.
madam, thank you. Good night, Neha, Madhavi, Sumedha, Sardesi madam. Thank you.
Yes, thank you, everyone. Thank you, Karnik madam, for joining.